You have to introduce the patient. You know, what is the name? Of course, you avoid the name, age and sex. You tell us.
Patient name Devi Singh, age 80 years old, male, address Chatari, and the chief complaint multiple swelling in neck, axilla and buttocks from 2 months.
And buttocks also.
Yes.
Okay.
So buttocks, groin region.
So you must be sure, na? Buttocks is different and groin is different. उसको वहीं रहने दीजिए, वहीं रहने दीजिए। अभी नहीं, अभी रुक जाइए, अभी कुछ आपके लिए बातचीत हो रही है।
HOPI patient was apparently well.
Not nothing like HOPI. History of present. When you see, focus on the lesions, है ना? And when I tell you, yes.
History of present illness. Patient was apparently well 2 months back when he experienced swelling in the left axilla first, and then right axilla, and then neck, and then groin region. Initially size is around 1 into 1 centimeter, then gradually progressive in size around 2 into 2 centimeter. And it is forming consistency as per patient and margins.
Okay. Now, whenever you are having a patient with complaints of multiple swellings, you have to start from the first swelling, where it is started.
Left axilla.
Left axilla. Then the second swelling appeared in the
Right axilla.
right axilla. Then the third appeared in the neck, right side and left side,
Yes.
and then the groin. So there is a sequential involvement of the lesions, and these are the common sites of lymph nodes: the axilla, the groin, and the cervical region. So whenever we have this type of presentation, we should think of lesions related to the lymphadenopathy or lesions which affect the reticuloendothelial system. So the reticuloendothelial system includes lymphadenopathy, lymph nodes. It includes the liver, it includes the spleen, and the thymus and the bone marrow. So these lesions, they may involve 1, 2, 3, or all the types of reticuloendothelial lesions. So when you plan the history, so you have to take history regarding these things. First of all, regarding lymphadenopathy. So you must be aware that what are the common causes of lymphadenopathy. And now it is no more a single group, there are multiple groups. So I will call it a generalized lymphadenopathy. So lymphadenopathy can be localized or generalized. If more than one are involved, then we call it generalized lymphadenopathy. So here you see there's cervical, axilla, both groin. So more than one groups are involved in this particular case. So it is likely to be a case of generalized lymphadenopathy. Of course, we have not done the examination as yet. But from the history, it is suggestive that they are small lesions, which were small, now they have become bigger. And it started from the axilla, then went to the neck, and then to the groin. So, of course, we cannot comment right now about the liver and spleen and bones, but that has to be part of the examination. Jai, let him go. Let the patient go. So, first of all, once you know that this is a generalized lymphadenopathy, so you have to just go through the causes of generalized lymphadenopathy. There are so many causes, starting from infective causes. So infective can be viral, it can be bacterial, it can be parasitic. Then it's acute or chronic. That means acute onset disease, chronic onset disease. Then it can be hematological causes, like chronic myeloid leukemia and other malignancies. Then finally it can be because of Hodgkin's disease. It can be primary Hodgkin's lymphoma, or it can be something else. So before any examination, you should have something in your mind that what you are looking for. Considering his age, actually tuberculosis is one disease which is very common in India, and it affects all ages, young adults, elderly. So that, of course, we cannot say right now it is not a case of tuberculosis, but it can be because of his endemic nature, plus the patient having this type of symptom even at this age. commonly in this age, it's more likely to be malignancies. However, Hodgkin's lymphoma again has two peaks. It is in the first and second decade of life, and then fourth to sixth decade of life. So he is in that second phase of the peak of the lymphoma. So that is also one consideration. And the third possibility is, say, lymphatic spread from primary disease, maybe carcinoma stomach, carcinoma colon, carcinoma prostate. So any of these diseases can give rise to metastasis in the lymph nodes, and it can be a regional lymph node or it can be a systemic lymph node. So that all these three things have to be taken into account when you go for the examination. But examination is classical. This is background knowledge that we are dealing with a reticuloendothelial system involvement, mainly multiple lymph node groups to be enrolled, and his age is how many years?
80 years.
80 years. So he is in that age where malignancy is more likely to be the cause, and then you start the examination. So in the examination, of course, the standard protocol has been followed, that you stand on the right side of the patient and you should have adequate light, you should have proper exposure, and again, without going into the systemic examination, you start with the general examination. So general examination, very quickly, vital signs: pulse, blood pressure, temperature, respiratory rate. So we just take in the hand and try to feel for the pulse. Pulse appears to be normal. He is afebrile, and of course blood pressure and temperature he is not having. We have to check the blood pressure. So that is the first thing. Then respiratory rate, and then the temperature as we have already taken. So pulse, blood pressure, temperature and respiratory rate. So they appear to be normal in this case. Of course, you have to take everything and record it. Then head to toe examination. You should start. Baba, thoda niche dekhiye, and you have to see the bulbar conjunctiva or icterus. There is no icterus. Then upar dekhiye, upar. There is pallor? No, no pallor. There is no pallor also. Then you see for lymph nodes. So one is general examination, in which you can see the submental, submandibular, preauricular, postauricular. Similarly on this side, there are some submandibular lymph nodes palpable here. Then the vertical chain. Of course, actually we come to the lymph nodes detail once we complete the general examination. But we know that there are lymphadenopathy in the cervical group, also in the axillary group, and we want to see for clubbing and cholinekia. There is no clubbing, no cholinekia, no pulmonary edema, and there is no change in the structure of the bony structures. ठीक है, पैर देखें, पैर खोलिए, and we see for the pedal edema. There is some mild pedal edema. You can see on the shin, on this side also. Let's see. Yes. So this is generally because of hypoproteinemia and many times associated with anemia. So that is the common cause, but there are other causes of pedal edema. So the only positive finding on general examination in this case is pedal edema, right? Now we go to the lymph node groups very specifically. Baba baithe rahiye. This is the submental. This is the submandibular. And I can feel one or two submandibular lymph nodes under my finger. Then this is the preauricular, this is the postauricular, and this is the occipital. So only submandibular lymph node on the left side is palpable. On this side, submental, no lymph node. Submandibular, there are few lymph nodes on the submandibular side. Preauricular, no. Postauricular, there are, of course, that we will come to later, and occipital. Now, in the vertical chain, you have jugulodigastric, jugulohomohyoid, and supraclavicular, and then the posterior triangle, which is the spinal accessory group. So in this particular case, you see there is upper jugular, mid jugular, and supraclavicular. All three groups are involved, plus the posterior group, that is spinal accessory group. And there are multiple lymph nodes. They are discrete. Discrete means they are not matted together. And you can pinch the skin separately. That means they are deep to the skin and they are mobile. You can see all of these lymph nodes are mobile. So there are multiple lymph nodes, supraclavicular lymph nodes also. They are palpable and they are mobile and they are multiple. On this side also, either focus karo, light look. You see the multiple lymph nodes, mainly, of course, upper jugular, mid jugular, and supraclavicular, not many, but posterior triangle, they are full of lymph nodes and of different sizes. Again, the skin is free and they are mobile, they are not matted together, and they are multiple of different sizes, ranging from say 0.5 to 2 centimeters, and they are firm in consistency, non-tender. In the anterior group, there are no anterior triangle, there is no lymph nodes palpable, right? So that is about. We will also like to see. थोड़ा सा वो ढीला कर दिया, हम बगल में जो आप कह रहे थे गांठ है, नहीं यहाँ पे. अच्छा, axilla, of course we have to see. You can see that axillary lymph node. थोड़ा रोशनी छोड़ तुम पीछे. You see? So I'll tell you how to examine the axilla. First of all, you ask him to keep his hand like this. Of course, we have to sit. Otherwise, he has to be at a high level. Yeah, this is the right position. If he is standing, then you stand. If he is sitting, you sit. And you ask him to put his hand on your shoulders, and you and you support from this side, so that he is not bending on that side. So roshni do. Now, then you start. You see the anterior axillary fold. So this anterior axillary fold, any lymph node group behind this anterior axillary fold will be the anterior group. So first of all, there are 5 groups: anterior, posterior, medial, lateral, and apical. Very simple. No, don't confuse. There are 5 groups: anterior, posterior, medial, lateral, and apical. Only 5 groups, not 6 groups. Central कहोगे तो 6 हो जाएगा. Anterior, posterior, lateral, medial, and apical. Right? So I will show you how to examine. So you ask the patient to put his hand on the shoulders, and you also support with this hand so that he does not tilt on one side. And then this is the anterior axillary fold which has become prominent. Your finger should go behind, and that will be the anterior group. I can feel one lymph node here in the anterior group. Now the second is the medial group against the chest wall, and there are multiple lymph nodes in the medial group, and they are mobile. Some are ranging from 1 centimeter to 3 centimeters in size, and maybe about 10-12 lymph nodes, they are together. Then you go for the apical group. For the apical group, of course, it's very difficult because at the highest level, I cannot feel any apical group, but most of them are the medial group. Then lateral group against the neck of humerus. This is the humerus, and this hand should be like this. So against the neck of humerus, you are trying to palpate the lateral group. First, this will complete this, then I will show you how to examine the posterior group. Similarly, on this side, he will put his hand here, and we support from this side. This is the anterior group. This is the medial group, which is again full of lymph nodes. Completely show, just dikhao. Multiple lymph nodes in the medial group. Anterior, no lymph nodes palpable. Medial, multiple group of lymph nodes palpable. And apical, piche, aage. Apical, again, I am not able to feel that. And the lateral, it will be like this. Again, see the so, no, at the neck of humerus, no lymph nodes palpable. So now the only group which remains is the posterior group. Baba, इसपे आ जाइए, इसपे बैठ जाइए. ऐसे हाथ रखिए अपने कंधे पे, इस पे. ऐसे, हाँ, शाबाश. Now what you see is इधर पीछे से फोल्ड लो. The posterior fold has become prominent. So your hand like this should go here inside. This is the posterior axillary fold, and this is again the posterior axillary fold. So what we are simultaneously we are examining both. The lymph nodes and here will be the posterior group. Lymph nodes here will be the posterior, and this should be anterior thumb, and all the four fingers should be inside. And this side there are no posterior group, but in this side I can feel few lymph nodes which are palpable. ठीक है बाबा, मैं बैठ जाइए अपनी जगह पे. So we have recorded large number of lymph nodes, and we'll not expose him, but just see the inguinal group if they are palpable. Yes, I can feel some lymph nodes in the inguinal region, and we just ask him to cough, see for any hernia also. बाबा इधर मुंह करके खांसिए. There is no hernia, okay. But I can feel the lymph nodes here. There are multiple lymph nodes on this side and also on this side. So there are two sites in which you see for inguinal lymph nodes. One is parallel to the inguinal ligament, and one is below the saphenous opening, where the great saphenous vein enters. So here you have to palpate according to the inguinal ligament parallel, and here you have to see the medial side of thigh for any lymph node running along the great saphenous vein. On this side again we are unable to feel for any lymph node in the great saphenous vein. So it is like vertical and it is like on both sides of the inguinal. So two groups are to be examined in the inguinal region. One is parallel to the inguinal ligament, and one is parallel to the saphenous opening and the upper part of the vessel which is opening into the deep veins. So after summarizing this, we can say that there are large number of lymph nodes in the neck, the large number of lymph nodes in the axilla, few lymph nodes in the inguinal region. And now we'll just like to have a look at the spleen and the liver, because that is very important before we will comment on the diagnosis. Baba, ek minute, bas ab last hai. So what we are going to do is ask him to take a deep breath. लंबी सांस लीजिए. This is the right lobe slightly below costal margin, and the left lobe also coming in the midline. So there is hepatomegaly about 4 centimeters below the costal margin and extending up to the mid nipple line. Spleen again we like to examine. सांस लीजिए. Spleen is not palpable. Baba, आप कमीज पहन लीजिए. So to summarize, this patient is an 80 years old male. He has noticed some initial lymph nodes in the neck, and then on left side, then the right side, then the axilla, and then groin. कुछ वजन कम हुआ पहले से आपका? हल्का पहना. अच्छा, भूख लगती है नहीं लगती है?
मुझे भूख लगती है. मैं आप एक बात बताऊं.
हाँ.
कि हिंदी में इसको जमजू कहते हैं.
हाँ.
जमजू वो रात को मुझे खाती थी बहुत ज्यादा.
क्या चीज?
जमजू कहते हैं हिंदी में. और वो मुझको यहाँ रात को सोने नहीं देती. मैंने बहुत इंतजाम किया. मैंने बहुत बड़ी मच्छरदानी बनवाई, उसमें भीतर बंद हो जाता था शटर कर लगा के, लेकिन वहाँ भी मच्छर भी खाते हैं अब भी, और वो भी बहुत बारीक बारीक होती है, वो खाती है.
ठीक है,
कुछ है.
So when you have a patient like this, 80 years old male with multiple lymph nodes enlargement with hepatomegaly, there is no ascites and no splenomegaly.
भूख खूब लगती है वैसे.
And he does not have any loss of weight, loss of appetite. So now the question is that how do we correlate all the findings? History examination and all the signs and symptoms should come together to make a diagnosis. So history may there is only say some insect bite or something which is saying we are not sure what was that insect bite, and he does not have. आपके घर में किसी को टीबी की बीमारी या कुछ इस तरह का?
हमारे घर में तो
अच्छा,
कोई नहीं, पिताजी की ना हमारे परिवार में
परिवार. So there is no history of tuberculosis in the family, but of course we cannot rule out in this environment where it's very common. But only thing which is unexplained is that in tuberculosis, the type of lymph nodes, they are matted together. They are not discrete, and many a times there is a sinus formation with so many lymph nodes enlarged, and they form a mass, and then they perforate the deep fascia, and they become a collar studded abscess, or they form a sinus. So nothing of that thing is present in this case. More so, it is generally seen in younger patients between second and third decade of life, and of course there may be a family history of tuberculosis. So all that is not there because these lymph nodes are discrete and they are, I would say, firm in consistency, not typically rubbery, which is a feature of Hodgkin's lymphoma. So tuberculosis we cannot 100% rule out unless we investigate. But clinically, we would say that it doesn't look like a case of tuberculosis. Now, the second question is then what it is. So again, I told you, lymphomas are very common, and diseases related to malignancies such as hematological malignancies, like chronic myeloid leukemia, chronic lymphatic leukemia. So these also give rise to multiple lymph nodes and hepatomegaly. So in this case, since his age points to that area where the chances of hematological malignancies is very high, so we would definitely consider that possibility. The third possibility is Hodgkin's lymphoma. As I told you, Hodgkin's lymphoma is also more common in younger age group. But of course, in the second peak, which occurs after 60 or 40 years, so that can be a possibility. So when you combine all these findings, we come to the conclusion that this is possibly a case of either hematological malignancy or a form of lymphoma. And what he says is an insect bite or something. So that has to be also evaluated because sometimes there's allergic phenomena in which the lymph nodes they enlarge, but that is a transient phase. Once the allergy is over, the swellings may subside. But we are not sure when this happened, and so that has to be also taken into account. So with this patient, elderly patient with multiple lymph nodes enlargement, with hepatomegaly and his age, we would like to consider the possibility of hematological malignancy as the first possibility, second Hodgkin's lymphoma or any type of lymphoma, and the third possibility would be tuberculosis. So these are the common conditions in which we have to make a diagnosis, and accordingly we have to investigate, and then we make a diagnosis. So how do we investigate this patient? Can you tell us something?
We will do, sir, FNAC.
Actually, we should start with CBC, and general blood picture, because we don't know it's a hematological malignancy or lymphatic malignancy, and so CBC would be very good investigation, and that will show the general blood picture. So it will show reticulocytes or malignant cells or those things. So if they are normal, then the second investigation is that we
एक चांस मुझे दो।
हाँ बोलिए।
मेरे में सांस की तकलीफ रहती थी पहले, और मैंने ये
आप बाबा 2 मिनट रुक जाइए, फिर आपकी पूरी सुनेंगे। So then, of course, then what other investigation you like to do? Yes, of course, chest X-ray, that would be a very good investigation, and of course, cough. If he is having cough, or you get sputum for tubercular examination, and we'll come to LFT. But first, we are trying to come to a diagnosis. I told you there are 3 or 4 possibilities, starting from hematological malignancies, then lymphomas, and then tuberculosis, and then any other allergic or some other. So these are the 4 possibilities. So first of all, we start with the possibility of hematological malignancies. So for that, general blood picture and bone marrow and all those things may be needed. Chest X-ray, it would be very helpful to know whether tuberculosis is a possibility. Of course, sputum examination, and then fine needle aspiration cytology, because there are multiple lymph nodes, you see, and very big lymph nodes. So we can take FNAC, and that will tell us what is the type of pathology inside. And if that is not possible, then we can take a true cut biopsy. And if that is not possible, we can do a lymph node biopsy. So lymph node biopsy may be needed for diagnosis of lymphoma, because unless until you say Reed-Sternberg cell and other findings, we cannot confirm the diagnosis of lymphoma. So after that, any other CT scan and other things would be needed to see the extent of the disease. Already it appears to be already spread all over the body. Maybe I told you the liver is enlarged. So LFT may be done, but CT scan and ultrasound may be the other options to see the other organ involvement. So now the only treatable condition which is very easy is tuberculosis. So unless and until we get the diagnostic evaluation, we are not sure how we are going to treat. So this is how you analyze the case. First you take a history, then you do the examination, and then you combine all the findings of history and examination. And then you think of the possibilities, possibility 1, possibility 2, possibility. Accordingly you investigate. So very simple investigations are needed to confirm the diagnosis most of the time. But if you are unable to diagnose, then you may resort to CT scan, MRI, and other investigations. Is that clear? Okay, thank you.